Hypermobility describes joints that stretch further than normal. For example, some hypermobile people can bend their thumbs backwards to their wrists, bend their knee joints backwards, put their leg behind the head or perform other contortionist tricks. It can affect one or more joints throughout the body. Causes: hypermobility generally results from one or more of the following: misaligned joints, abnormally shaped ends of one or more bones at a joint, a type 1 collagen or other connective tissue defect resulting in weakened ligaments, ligamentous laxity, muscles and tendons. This same defect also results in weakened bones, which may result in osteoporosis and fractures. Abnormal joint proprioception: these abnormalities cause abnormal joint stress, meaning that the joints can wear out, leading to osteoarthritis. The condition tends to run in families, suggesting that a genetic basis for at least some forms of hypermobility. The term double-jointed is often used to describe hypermobility. However, the name is a misnomer and should not be taken literally, as hypermobile joints are not double-dextra in any sense. Most people have hypermobility with no other symptoms. Approximately 5% of the healthy population have one or more hypermobile joints. However, people with joint hypermobility syndrome are subject to many difficulties. For example, their joints may be easily injured, be more prone to complete dislocation due to the weakly stabilized joint, and they may develop problems from muscle fatigue. Hypermobility syndrome can lead to chronic pain or even disability in severe cases. Musical instrumentalists with hypermobile fingers may have difficulties when fingers collapse into the finger-locking position, or may display superior abilities due to their increased range of motion for fingering, such as in playing a violin or cello. Hypermobility may be symptomatic of a serious medical condition, such as Stickler syndrome, Ehlers-Danlos syndrome, Marfan syndrome, Lewy-Dietz syndrome, rheumatoid arthritis, osteogenesis imperfecta, lupus, polio, Down syndrome, Morquio syndrome, cleidocranial dysostosis or myotonia congenita. Hypermobility has been associated with chronic fatigue syndrome and fibromyalgia. Hypermobility causes physical trauma. These conditions often, in turn, cause physical and/or emotional trauma and are possible triggers for conditions such as fibromyalgia. During pregnancy, the body releases certain hormones that alter ligament physiology, easing the stretching needed to accommodate fetal growth as well as the birthing process. For women with hypermobility conditions, pregnancy-related pelvic girdle, pain during pregnancy can be debilitating due to these two converging factors. Pain often inhibits such women from standing up or walking during pregnancy. The pregnant patient may be forced to use a bedpan and/or a wheelchair during pregnancy. The pregnant woman with hypermobile joints will often be in significant pain as muscles and joints adapt to the pregnancy. Symptoms of hypermobility include a dull but intense pain around the knee and ankle joints and the soles of the feet. The pain and discomfort affecting these body parts can be alleviated by using custom orthoses. Anxiety and joint hypermobility. A 1998 study linked panic disorders and joint hypermobility. The prevalence of joint hypermobility syndrome among patients with a panic disorder was 67.7% compared to the control psychiatric group. Women and younger subjects were found to be over 20 times more likely to have hypermobile joints than their counterparts in the control group. The study also found a higher prevalence for mitral valve prolapse. Depression and anxiety were other correlated symptoms. A 2003 study found that 78% of people with hypermobility also had orthostatic intolerance, which can lead to chronically high adrenaline and chronic anxiety. Hypermobility syndrome. Hypermobility syndrome is generally considered to comprise hypermobility together with other symptoms, such as myalgia and arthralgia. It is relatively common among children and affects more females than males. Causes. Current thinking suggests 4 causative factors: the shape of the ends of the benes. Some joints normally have a large range of movement, such as the shoulder and hip. Both are ball and socket joints. If a shallow rather than a deep socket is inherited, a relatively large range of movement will be possible. If the socket is particularly shallow, then the joint may dislocate easily. Protein deficiency or hormone problems. Ligaments are made up of several types of protein fiber. These proteins include elastin, which gives elasticity and which may be altered in some people. Female sex hormones alter collagen proteins. Women are generally more supple just before a period and even more so in the latter stages of pregnancy, because of a hormone called relaxin that allows the pelvis to expand so the head of the baby can pass. Joint mobility differs by race, which may reflect differences in collagen proteins structure. People from the Indian subcontinent, for example, often have more supple hands than Caucasians. Muscle tonia. The tone of muscles is controlled by the nervous system, and influences range of movement. Special techniques can change muscle tone and increase flexibility. Yoga, for example, can help to relax muscles and make the joints more supple. Gymnasts and athletes can sometimes acquire hypermobility in some joints through activity. Proprioception. Compromised ability to detect exact joint body position with closed eyes may lead to overstretching and hypermobile joints. Hypermobility can also be caused by connective tissue disorders, such as Ehlers-Danlos syndrome and Marfan syndrome. Joint hypermobility is a common symptom for both. EDS has numerous subtypes. Most include hypermobility in some degree. When hypermobility is the main symptom, then EDS hypermobility type is likely. People with EDS-HT suffer frequent joint dislocations and subluxations, with or without trauma, sometimes spontaneously. Commonly, hypermobility is dismissed by medical professionals as non-significant. Symptoms: people with hypermobility syndrome may develop other conditions caused by their unstable joints. These conditions include joint instability causing frequent sprains, tendinitis, or bursitis when doing activities that would not affect others, joint pain, early onset osteoarthritis, subluxations or dislocations, especially in the shoulder. Knee pain, back pain, prolapsed discs or spondylolisthesis, joints that make clicking noises, susceptibility to whiplash, temporomandibular joint syndrome also known as TMJ, increased nerve compression disorders, the ability of finger locking, poor response to anesthetic or pain medication, growing pains as described in children in late afternoon or night, diagnosis. Joint hypermobility shares symptoms with other conditions such as Marfan syndrome, Ehlers-Danlos syndrome, and osteogenesis imperfecta. Experts in connective tissue disorders formally agreed that severe forms of hypermobility syndrome and mild forms of Ehlers-Danlos syndrome hypermobility type are the same disorder. Generalized hypermobility is a common feature in all these hereditary connective tissue disorders and many features overlap, but often features are present that enable differentiating these disorders. The inheritance pattern of Ehlers-Danlos syndrome varies by type. The arthrochalasia, classic, hypermobility and vascular forms usually have an autosomal dominant pattern of inheritance. Autosomal dominant inheritance occurs when one copy of a gene in each cell is sufficient to cause a disorder. In some cases, an affected person inherits the mutation from one affected parent. Other cases result from new gene mutations. Such cases can occur in people with no history of the disorder in their family. The dermatosparaxis and kyphoscoliosis types of EDS and some cases of the classic and hypermobility forms are inherited in an autosomal recessive pattern. In autosomal recessive inheritance, two copies of the gene in each cell are altered. Most often, both parents of an individual with an autosomal recessive disorder are carriers of one copy of the altered gene but do not show signs and symptoms of the disorder. Brighton Criteria. As of July 2000, hypermobility was diagnosed using the Brighton Criteria. The Brighton criteria do not replace the Baton score but instead use the previous criteria in conjunction with other symptoms. HMS is diagnosed in the presence of either two major criteria, one major and two minor criteria, or four minor criteria. The criteria are, major criteria, a Baton score of 4/9 or more, arthralgia for more than 3 months in 4 or more joints, minor criteria, a Baton score of 1, 2 or 3/9, arthralgia in 1 to 3 joints or back pain, spondylosis, Spondylolysis, spondylolisthesis. Dislocation, subluxation in more than one joint, or in one joint on more than one occasion. Soft tissue rheumatism. 3 lesions. Marfanoid habitus. Abnormal skin, striae, hyperextensibility, thin skin, papyraceous scarring. Eye signs, drooping eyelids, myopia or antimongoloid slant, varicose veins or hernia or uterine rectal prolapse. Baton score. The Baton score is an edited version of the Carter-Wilkinson scoring system which was used for many years as an indicator of widespread hypermobility. Medical professionals varied in their interpretations of the results, some accepting as low as 1/9 and some 4/9 as a diagnosis of HMS. Therefore it was incorporated, with clearer guidelines, into the Brighton Criteria. The Baton score is measured by adding 1 point for each of the following: placing flat hands on the floor with straight legs, left knee bending backward, right knee bending backward, left elbow bending backward, right elbow bending backward, left thumb touching the forearm, right thumb touching the forearm, left little finger bending backward past 90 degrees, right little finger bending backward past 90 degrees. Treatments, physical therapy. It is important that hypermobile individuals remain fit, even more so than the average individual, to prevent recurrent injuries. Regular exercise and physical therapy or hydrotherapy can reduce symptoms because strong muscles increase joint stability. These treatments can also help by stretching tight, overused muscles and ensuring the person uses joints within the ideal ranges of motion, avoiding hyperextension or hyperflexion. Low-impact exercise such as pilates or Tai Chi is usually recommended as they are less likely to cause injury than high-impact exercise or contact sports. Moist hot packs can relieve the pain of aching joints and muscles. For some patients, ice packs also help to relieve pain. In many cases alternating the two helps relieve the pain. Medication. Medications frequently used to reduce pain and inflammation caused by hypermobility include analgesics, anti-inflammatory drugs, and tricyclic antidepressants. Some sufferers may benefit from medications such as steroid injections or gabapentin, a drug originally used for treating epilepsy. Tramadol, a non-narcotic yet opioid pain reliever that is nearly as effective as narcotics, has been used in England to treat HMS joint pain, and it is available either by prescription from a doctor in the United States or from Mexico. Benzodiazepines are also used in HMS sufferers who experience painful muscle spasms around loose joints. Lifestyle modification. For some hypermobiles, lifestyle changes decrease symptom severity. In general, activity that increases pain is to be avoided. For example, typing can reduce pain from writing. Voice control software or a more ergonomic keyboard can reduce pain from typing. Bent knees or sitting can reduce pain from standing. Stretching, as in some forms of yoga and weightlifting, frequently produce unwanted symptoms. Use of low-impact elliptical training machines can replace high-impact running. Pain-free swimming may require a kickboard or extra care to avoid hyperextending elbow and other joints. Weakened ligaments and muscles contribute to poor posture, which may contribute to other medical conditions. Isometric exercise avoids hyperextension and contributes to strength. Other treatments, bracing can be helpful when joints are injured or painful, as long as muscle strength is properly maintained. Prolotherapy injections been reported to help for some. Allegedly it can strengthen degenerate tendons and ligaments, as opposed to masking symptoms. It is generally suggested that patients with HMS take longer to respond to prolotherapy compared to the average patient, and full recovery can potentially take months to years. References. Graham at the Revised Criteria for the Diagnosis of Benign Joint Hypermobility Syndrome. J. Rheumatal. 2000. 27 a Euro 1779, 10, Genetics Home Reference, 1, External links, Gurley Green S. Living with a Hypermobility Syndrome. Rheumatology 40, 487 a Euro 9 doi, 10.109,340.5.487. PMIDA 11,371,654, Hypermobile, a blog about Ehlers-Danlos syndrome. The lack of clinical distinction between the hypermobility type of Ehlers-Danlos syndrome and the joint hypermobility syndrome, joint hypermobility syndrome. Indian Journal of Rheumatology 5, 150 The Disability Handbook on Arthritis, Marta N. Santos R., Balbina, Porter M., Gago J., Molina L., Duracube J.C. Association between joint hypermobility syndrome and panic disorder. Amj Psychiatry 155, 1578 to 83. PMIDA 9812121. The Hypermobility Syndrome Association is a charity run by and for people diagnosed with a hypermobility syndrome.